ओके गुड मॉर्निंग क्लास सुनिरहेछ मेरो कुरा सुनिरहेछ मेरो भोइस ऑडिबल छ ओके थ्यांक यू ल टुडे वी हैव अ टपिक ट्युबरकुलोसिस अफ द स्पाइन हैन लास्ट टाइम मैले स्पाइन को क्लास लिए थे डिफरेंट डिफर्मिटीज डिसअर्डरहरु त्यसकै कति पोर्सनहरु चाहिँ यसमा अलिअलि रिपिट पनि हुन्छ है ओके So, starting with the history, it has been documented that tuberculosis of spine is known to us from since around 5,000 years old mummies. It was documented from those mummies, in those Egyptian mummies around 5,000 years old. So it is quite an ancient disease that is with us till date. Percival Port in 1779 was the first person to diagnose the tuberculosis of the spine. He was the first person in 1779 who documented the tuberculosis infection of the spine. So tuberculosis of the spine is a huge global burden for us. And of those, the patient, 1/5, around 20% of the people are from the India, that is our neighboring country. So with the free flow of the people from India and Nepal, that is quite common for us. With the same temperate environment, tuberculosis is present in Nepal also. This is in general, not the spine, whole tuberculosis of the, including pulmonary and extrapulmonary. 2018 data shows in Nepal we have incidence of 151. Incidence means we talk about in per lakh, in 1 lakh 100,000, 151 cases till in the year 2018. And of the all patient, all the tuberculosis cases, 3% of the patient they suffer from the skeletal tuberculosis. Skeletal, I'm talking about in general, whole skeletal system. And of that 3% skeletal tuberculosis, half, 50% constitutes the vertebral tuberculosis. That is tuberculosis of the spine, or we say tubercular spondylosis. Almost 50% are from the pediatric age group. And it is the second greatest killer next to HIV. So World TB Day we celebrate in March 24th March, and the slogan for 2020 World TB Day is "It's time to end TB." So this is the slogan, and WHO had aimed early diagnosis, expeditious medical treatment, aggressive surgical approach, and prevention of deformity, as these are the aims set by the WHO for the containment, say towards the end of the tuberculosis. These are the approaches. Okay, so anatomy, I think we have already discussed in the last lecture. It constitute the body, the anterior part, and the appendiceal part. This is pedicle, lamina, transverse process, and the spinous process, and this articular facet. Okay. Regional distribution, dorsal spine, thoracic spine constitute the most, 42% of the tuberculosis of the skeletal system, say spine, tuberculosis of the spine. And next most common is the lumbar. Okay, thoracic, then comes the lumbar. Coming to the pathology, it is tuberculosis of the spine is always secondary. It's not the primary. Primary is mostly in the lungs, viscera, or lymph nodes. These are the primary infections, and tuberculosis of the spine is always secondary. And mostly it is due to the hematogenous spread, Batson's plexus of veins around the spine, the spinal cord. These are the veins through which the hematogenous spreads occurs. And it is because of the pulmonary infection in the lungs, the tuberculosis, and the dorsal spine is quite near to it, so there is most common spread to the thoracic spine. And as you might know better than me, it is a delayed hypersensitive type immune reaction. You have just come across the pathology subjects, and so delayed hypersensitive immune reaction with inflammatory reaction with Langerhans type of giant cells. You can see in this picture with the Langerhans type of giant cell, epithelioid cells, okay, and the lymphocytes. The granulation tissue proliferates, producing thrombosis of the vessels. And ultimately, there is a granuloma formation with cageation, cageous necrosis, and as in the adjacent discs degeneration occurs due to the end arteritis. Okay, and completely this adjacent vessel, the inflate vessels, arterioles are the end arteries. So when they are obliterated, there is a ischemia around the discs, and this results in destruction. And ultimately, there will be weakening of the trabeculae, and with the axial loading, the compression and collapse of the vertebra occurs. We can see starting up right here anteriorly around the paradiscal area around the discs. Slowly, this becomes irregular and collapse of the vertebra with the continuous axial loading. So slowly, when there is inflammation and granulation tissue formation occurs, there will be abscess, and in tuberculosis we call it cold abscess because of absence of the active signs of inflammation. So these are cold abscess. When the vertebral collapse occurs, the debris formed there, they either go anteriorly along the anterolongitudinal ligament, so or go posteriorly along the spinal canal, compressing the spinal cord and the intervertebral foramen. Okay, so as I talked about cold abscess, the cold abscess, the liquefied tissue in the body, which is the body's defense reaction to the foreign material. There are no signs of inflammation, so this is called the cold abscess, and it can track in any direction, along the musculofacial planes or neurovascular bundles. Okay, the different planes in which it can spread is, if it is in the cervical tuberculosis, then the paraspinal regions of the back, anterior or posterior cervical triangles, and brachial plexus, along the brachial plexus of the axilla, and in the thoracic spine, the intercostal spaces, the intercostal vessels, along the intercostal vessels, they track and they present with the swelling called abscess around the posterior aspect of the trunk and the posterolateral aspect of the thorax. Okay, in the dorsolumbar region, it can track along the psoas muscles. So there might be spasm of the psoas muscles, and later when it trickles down, as we know, the psoas and the iliacus have the same insertion at the reciprocanter iliacus. The collection, it spreads into the iliacus muscles sheath, and ultimately it can go up to the thigh, and even to the medial malleolus around the distal, around the ankle also. It can trickle down up to that great toe. So it can, all the way from the thoracic spine, it can spread up to the great toe. As recently as I have talked, this is the psoas muscle, and this is the iliacus, and the abscess around the thoracic spine, thoracolumbar. It trickles down and presents around the collection over here, and this irritates the muscle. So there will be flexed attitude of the limb. Okay. So types of the vertebral involvement. Most common is the paradiscal lesion. This like this. Paradix means around the disc. This is the vertebra. This space is the disc space. So around the disc, as I earlier I discussed in the pathology, there will be the end arteritis and the degeneration of the disc, ischemia and degeneration of the disc. So this is the most common type, paradiscal. And this type 2, involvement of the vertebral body, this is the central, and this central type is due to the spread from the venous spread. Okay, this type 3, this anterior type, when it spreads either from the paradiscal type or the vertebral body. Central type lesion, it spreads when it spreads anteriorly, or sometimes only collection is visible in the anterior part. This is called anterior type of the involvement. And appendiceal means all the posterior elements like pedicle, lamina, transverse process, spinous process, all the posterior parts, whatever they are, these are the appendiceal. Okay. As I discussed, paradiscal type, it is the most common type, and this involves the ultimately collapse of the vertebra and the deformity, narrowing the clinical finding, the radiological finding seen in this is the irregularity of the disc space and narrowing of the disc space. Okay, like in this picture, we can see there is irregularity, disc space involvement. In this T2-weighted image, there is a hyperdensity in this disc. Okay, and this you can see the appreciate the huge collection in this area that has displaced this. This is the kidney. Okay, this collection has displaced the kidney like compared to this side. Okay. And in this axial cord, we can see the collection in the spinal canal. This is the spinal canal. The spinal cord is right here, the circular area, and this arrow is showing at the collection. The anterior type of lesion is soft periosteal extension under the interlongitudinal ligament. Okay, there will be periosteal stripping and ultimately avascular necrosis and more susceptible for the infection. So, sorry, in the X-ray we can only appreciate the anterior scalloping of the anterior vertebra due to the erosion from the granulation tissue. So, collapse of the vertebral body and diminution of space, disc space is minimal in this, and this is common in the thoracic spine in children. Okay, central type of lesion in the body, disc is not involved, and mostly from the dorsal venous plexus, and it results in the concentric collapse of the vertebra. We call it vertebral plana. When the vertebra is concentrically collapses, when it is in the body anterior part, there will be wedging. There will be wedging of the vertebra. But in the central, when it involves the central part, there will be concentric collapse, and the all together, the anterior and posterior, both the heights are decreased. Like in this picture, there is in this picture slightly anterior height is more compressed than the posterior, but in this picture we can appreciate there is concentric central lesion and concentric collapse of the vertebra in this MRI. Okay, appendicial, the isolated infection involving the pedicles, lamina, transverse process, and the spinous process. These are quite rare, isolated ones. These constitute around less than 5% only, but in conjunction with the other paradiscal and central type of lesion, type of lesion, in conjunction along with this type of common infections, these are also visible in around 30% of the cases. So to visualize these associated appendicial lesions, MRI and bone scans are very important for diagnosis. Okay. These are the appendiceal, like in the involving the spinous process and collection is in the cervical vertebra. So clinically, how they present? Clinically, as tuberculosis, as we all know, these are the constitutional symptoms: mild grade of fever, evening rise of temperature, and weakness, weight loss, loss of appetite. Constitutional symptoms, these are commonly present. However, it's not mandatory that this should be always present. Another most common finding is the pain in the back. This is the most common, pain in the back, as thoracic and lumbar region are the commonest ones. So they present as the pain in the back. Sometimes we may see as a swelling like this, and the stiffness of the, due to the spasm of the muscles, there will be stiffness, and ultimately there can be the neurological symptoms when it compromises the spinal canal and the exiting nerve roots, and obviously when there is collapse of the vertebra, we can have this deformities. So on examination, attitude and gait. In when there is a collection in the cervical region, wry neck, or we can say torticollis. We commonly say due to the spasm of the muscles. In thoracic spine, military attitude. The patient try to compensate their deformity in the thoracic spine way by expanding their chest and be standing upright to maintain the posture. That is a military attitude. In lumbosacral region, we say when elder man's gait. Elder man's gait is a typical gait when there is a lumbosacral tuberculosis. There is, due to the spasm, there is an increase in the lumbar lordosis. So to compensate that lordosis, patient pushes the neck and upper trunk towards back to maintain the posture. So with the abdomen protuberant anteriorly and the head in the upper trunk back, and with the wide-based gait, patient walks with that attitude, and that is elderman's gait. Okay. In the lower lumbar, there will be pronounced lordosis is visible. That is the compensatory. The lordosis is the compensation to the flexion attitude of the psoas spasm. The psoas spasm, when it is, as we all know, psoas is a strong hip flexor. Because of the spasm, there will be flexion attitude of the hip. So to maintain the upright posture, the patient increases the lordosis to maintain the upright posture, like is shown in this picture. Okay. So deformity of the spine. So it can be of different types. When single vertebra is involved, we call it knuckle gibbous, knuckle kyphosis, and when up to two to three vertebra is angular gibbous, angular kyphosis, and more than 3 vertebra involvement, round kyphosis. Okay, kyphosis is also 3 types, as I have already discussed in the previous lecture also. And when there is lateral deviation, that is scoliosis, and as shown in this picture, there might be some scoliosis. This is the typical of kyphosis. And lordosis, increased lordosis also when it's the lumbar spine. Abscess, sinus formation, if it is in the cervical region, dysphagia, dyspnea due to the retropharyngeal collection, hoarseness of the voice. In the upper thoracic region, flex psoas abscess, flex contraction of the hip. All the thoracic abscess, it can all trickle down. These are the typical places where we can see the collection: the retropharyngeal, neck, axilla, paravertebral, and the lumbars, the petit triangle, gluteal region. These are the site where, like, we can see, appreciate this swelling in this picture. Okay, and we don't have any signs of inflammation in this. So these are the, this might be the cold abscess. We should think in that way. So movement of the, due to the spasm, movement of the spine is restricted in all different planes, and the paralysis in up to 10 to 30% of the patient usually is incomplete and most common in the thoracic region. This is because in thoracic region, the spinal canal is quite narrow, a small diameter of the spinal canal. So whatever gets collected whenever there is a flexion, the kyphosis deformity, because of both the granulation tissue as well as the bony spikes or whatever bony deformity is there, that significantly decreases the canal diameter, and this thoracic region involvement is the most common for the paralysis. So diagnosis, we can make, we can approach through the blood and other diagnosis and radiological. Let's go with the radiological diagnosis first. X-ray, CT scan, MRI, bone scan. Okay. X-ray, what we can appreciate, these X-ray changes are not seen once the disease starts. The X-ray changes are seen only after the around 2 to 3 months of infection. This is because to be visualized in the X-ray, up to 30% of the bone should be lost to have the radiological appearance of the change. So it takes time for the 30% of the bone to get lost for the radiological visualization in the X-ray. Whatever happens, the appearance the seen is haziness and local osteoporosis of the in plates of the adjacent vertebra. Like here, these are the irregularities of the in plates, and narrowing of the intervertebral disc. As compared to this disc space, this disc space is quite narrow. Okay. Sorry. And the late changes in late stage paravertebral shadow due to the cannulation collection, enter wedging and compression collapse, deformity, central or concentric collapse, as we have seen, destruction of the posterior elements is seen in that 30% of the cases when associated with the other lesions. As earlier said, it takes around 3 to 5 months. So there are also different radiological shadows in the based on the different regions. In cervical region, we have to be peculiar, more focused in the retropharyngeal space. Whatever the retropharyngeal space it has, it is said that in anterior part of the C2 vertebra, if it is more than 4 mm, then that is pathological, the shadow. So this retropharyngeal space increase in the retropharyngeal space shadow. Upper thoracic mediastinum V-shaped shadow. Upper thoracic, change in the contour of the tracheal shadow. Below the fourth thoracic, fusiform or broadness shadow. Below D10, bilateral widening of the psoas muscle, psoas shadow, widening of the psoas shadow. And aneurysmal phenomenon, tense thoracic vertebral abscess showing scalloping effect. As in this in this X-ray, there is widening. This is the bird nest appearance. Okay, and in this we see the wedging of the vertebra. In this picture also we can see the concentric. There is a compression. There is a widening of this shadow and another shadow also. There are two shadows visible in this X-ray. So next diagnostic choice is bone CT scan. This quantifies the bone destruction, amount of the bone destruction. Once we have to take the patient for the operative intervention, this investigation is quite useful because we have to decide whether the patient needs stabilization or whether the patient needs any bone fixation instruments or not. So to decide that how much of the bone is lost, bone destruction, to quantify CT scan is necessary. Calcification in the psoas around pathognomic for the tuberculosis. These scans are also quite useful in the for the localization of the areas which are not readily visible with the X-ray, like the craniovertebral junction. Right here, the craniovertebral junction is not easily seen in the X-ray. Cervical-dorsal junction, cervical-thoracic junction, C5, C71, and the sacrum or sacroiliac joint. These are the regions that are useful. So MRI. This investigation is quite useful in the very early phase when we are very suspicious of the case and X-ray doesn't show any sign. Then MRI is the investigation of choice. So, and this is also very useful for the skip lesions when they are the adjacent, like in this scan, and the lesions can be seen in this vertebra as well as this disc space. So these skip lesions we can easily visualize in the MRI, and it also gives us information about the spinal cord involvement, spinal arachnoiditis, whether the spinal cord is grossly damaged, we call it myelomalacia. This can be seen in the MRI. Like in this picture, we can see the intercollection, wedging of the vertebra, intercollection in the collection anterior of that vertebra, like same here. This portion, there is a destruction, and this collection is compressing the neural foramen. Okay, similar in this picture, there is collection both on both sides, both medial and lateral, both on the left and right side in this coronal section. Bone scan. These are useful in detecting the lesions of the size around 5 millimeter. So these are useful in those cases. In case uptake is seen with active tuberculosis, avascular segment and abscess show cold spot due to the decreased uptake. Okay, these are highly sensitive but not specific. As previously also in the last lecture, we discussed the angle of kyphosis. We measure in two ways: Cox angle, one line along the posterior part of the vertebral body that crosses and makes angle, that is the Cox angle, and another way is through the superior end plate of the adjacent to normal vertebra. Superior end plate and inferior end plate. Okay, superior end plate one line, inferior end plate one line. This gives the angle, kyphotic Cobb's angle. Coming to the classification, Kumar et al. In 88, they gave clinico-radiological classification. It constitutes both clinical and radiological pictures. Okay, they have classified into 5 stages: pre-destructive, in which the lesions are not seen in the X-ray. MRI only show marrow edema, but symptoms are present. They're like symptoms inside spasm of the perivertebral muscle, straightening of the curvature. So in the early stage, in less than 2 months, these are the pre-destructive stage. And next is the early destructive. When it crosses 2 to 4 months, there is slowly this vertebral body or the discs around the disc, the changes starts appearing. So the decrease in the disc space, paradiscal erosion, MRI marrow edema, break of the osseous margin, CT scan marginal erosions, and we can see these changes in the 2 to 4 months. And next is the mild angular kyphosis, when the 2 to 3 vertebrae are involvement, and mild is up to 30 degree. Okay, 10 to 30 degree of the kyphosis. Then that could be appreciated up to 4 to 9 months. And and the next is the moderate angular kyphosis, when the angle of kyphosis is around 30 up to 60 degree, 40 to 60 degree, and severe kyphosis when it is more than severe. More than 60 degree. Okay. Sorry. The severe picture is usually visualized. It takes up to 2 years, and this is quite common in our part of the world. Especially they come from the far remote areas, and these appearance of the kyphosis in these range, and it is very rare for the patient to visit in these 2 stages, pre-destructive and early destructive. We usually find patient in this early destructive and mild angular kyphosis phase in our part. So lab test, what are the tests we have? Montu test or tubercular skin test, TST we call it, and ESR, they are markedly elevated but not specific. ELISA for antibody to the mycobacterial antigen 6, it has sensitivity of around 94%, specificity of 100%, PCR of sensitivity, low sensitivity only. Another investigation that has been approved in the Western world, and we are yet to take up, is the interferon gamma release assay. Okay, the T cells, the delayed type hypersensitive reaction to the tubercular antigen, and the T cell release interferon gamma, and the quantification of this interferon gamma to the antigens ES86, CBF10, and TB7.7. These are the different tests. And interferon gamma assay or IGRAs, we call it commonly. And another is the T-spot TB test. T-spot test. These 2 are the tests with the higher sensitivity and specificity. Microbiological studies. Biopsy, as we know, this is the diagnostic investigation. We can do it as CT or ultrasound guided or open biopsy, and whatever we get samples, we go with the gel densin staining and culture of the bacilli. You people better know than me the culture media for the tubercular bacilli. That is important. Tubercular bacilli results are available only after a few weeks. It takes quite a long time for the growth of the bacilli. So we have to rush. Then we are getting short of time. Histology, tuberculosis. Okay, the differential diagnosis: the other tubercular infection, pyogenic brucellosis, and neoplastic condition, degenerative osteoporotic condition, traumatic condition, congenital defects, spinal osteochondrosis. These are the tuberculosis. We have to differentiate with the brucellosis. These are common in our part of the world also. Okay. So neurological complication, in around 10 to 30% of the cases, they develop neurological complication in the first 3 decades of their life, and most common in the thoracic region. Okay. These are due to the inflammatory edema, and the extradural mass, the mass effect. Commonest mechanism is the mass effect, bony disorder, sequestrum, gibbus, and subluxation of the displacement of the compression with the vertebra. Intrinsic changes in the cord, peridural fibrosis due to the healing process, infarction, and myelomalacia, gliosis, atrophy. Okay, the SEDDON has classified of the tubercular paraplegia into two types: early onset, late onset. Okay, early onset, if it develops within the first 2 years, early onset, these are seen in the active disease and these have a better prognosis. Whereas in the paralysis, if it develops after 2 years and associated with the heel disease, these are due to the mechanical compression, and so they need operation, and they have poor prognosis. So SEDDONS, paraplegia of early onset, late onset. Okay, Tully and Kumar have graded the paraplegia into 4 different types. Paraplegia, tubercular paraplegia. Okay, up to this step may not be required for you people, but it is good to know. Negligible when the patient doesn't know, but we can appreciate the clonus, upper motor neuron signs are visible. Okay, we can elicit. Mild when patient is aware of the deficit but manages to walk. Moderate, non-ambulatory patient, sensory deficit less than 50%. Severe flexor spasm and paralysis, and more than 50% of the sensory deficit is sphincter involvement. Okay. Sequence of the paralysis, this is not required up to this level. Okay, treatment coming to the objective are to eradicate or at least arrest the disease. Treat the major complications like paraplegia and prevent or correct the deformity. So it is Tully is the renowned doctor in India who has given the treatment regimen for the tuberculosis of the spine, also popularly known as middle path regime. Okay, bed rest with or without traction. If there is gross deformity is there, we may need the traction. Drugs, the antitubercular drugs, whatever is there, the first line, second line drugs, you should be thorough with these things. Okay, the 5 first line drugs and the SRZES. Okay, isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin. The first line and the second line drugs. Okay, and we should be also thorough with our government national guidelines. Recently, they have modified. Yeah, in earlier days we had 3 types of tuberculosis, but now they have classified into broadly 2 categories: Cat 1 and Cat 2 only. Earlier 3 categories. Okay, and the patient needs to be followed on the 3 monthly basis, gradual mobilization with exercise. For the abscess, repeat aspiration, streptomycin injection installation in the abscess, and surgical evacuation. Surgical evacuation if symptomatic. Sinuses, they usually heal by 6 to 12 weeks of antitubercular drugs. If neurological complications are associated, not all the patient needs surgery. Okay, there are certain indications for the surgery. No improvement of signs and symptoms even after 3 to 6 weeks of the treatment. Patient develops neurological complications while on the treatment, and neurological status becomes worsening while undergoing the treatment. Recurrence, once the neurological symptoms have resolved but again reappear, then these are the stages when we need the surgical intervention. So if the patient is not responsive in around 3 to 6 months of chemotherapy with the antitubercular drug, we need operative treatment. Excision surgery, posterior spinal arthrodesis, and postoperatively hard bed rest for 2 to 3 weeks and neurological recovery. Brace may be required for 3 years, up to 2 years. Okay. Okay. These drugs in the middle path regime, different phase intensive phase, this was given by the Tully. This is not commonly followed in our country. They have suggested after 5 to 6 months of isoniazid and rifampicin associated ofloxacin. This comes in the second line job in the intensive phase, and continuation phase up to 7 to 8 months for the persisters, slow growers, and dormant or intracellular mycobacteria. The continuation phase is required 7 to 8 months, and isoniazid and pyrazinamide 3 to 4 months, followed by rifampicin 4 to 5 months. These are the protocol shared by the middle pathways in this truly. But in Nepal, the National Tuberculosis Program, they have developed the protocol, and this is the recent one. And the extra complicated pulmonary or severe extrapulmonary cases like CNS, tuberculosis, tubercular pericarditis, musculoskeletal TB, miliary TB, they have categorized all these cases in a single place, and they have given the intensive phase of 2 HRZD, means 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol. And you should be thorough with the dose of these drugs also, okay? And continuation phase of 7 to 10 months of the isoniazid, rifampicin, and ethambutol. These all three drugs are given for the continuation phase up to 7 to 10 months. So it may take up to a year. Recently, there are published data in which they are doing around 6 months of the drug, and they have already started doing. If it involves the joints, tubercular arthritis, they after 6 months or during the course of the anti-tubercular therapy, also they are doing total knee and total hip arthroplasty. Similarly, in the spine also they are doing active surgery earlier also, other than this infection control. So the recent data are in favor of less months of anti-tubercular therapy, but in Nepal, and to be on the safe side, we still give around 9 to 12 months. And the common protocol is, if the spine is involved, only spine and no neurological involvement, we give 9 months of anti-tubercular therapy, and if there is neurological signs and symptoms, 12 months of anti-tubercular therapy. So prognostic factor, the better prognostic factor are partial involvement, short duration, slower onset, young people, good general condition, active disease, kyphotic deformity of smaller, less than 60 degree. Okay, surgical treatment, all these are not required, such as laminectomy, laminotomy, costotransversectomy, Calvage operation. Okay, these are not required in this level. Just the name of the one is spinal tumor syndrome, that is commonly used in tuberculosis when nothing is visible in the X-ray, but still the neurological findings are there, and MRI shows some neurological findings, neural compression there. Then we call it spinal tumor syndrome. Okay. So types of surgery: decompression and plus minus fusion, anterior transposition of the cord, laminectomy. Different surgical approaches are there. Anterior approach in cervical, we generally go anteriorly, anterolaterally in the thoracic, extraperitoneal or transverse vertebrectomy in the lumbar, lumbosacral. These are the spinal braces: 4-post brace, Minerva jacket, Somi brace. These are the different braces. And Knight-Taylor brace. This is for the D4 to L2, Knight-Taylor brace. And the AS brace, anterospinal hyperextension brace. This is the anterospinal hyperextension for the kyphotic deformity. This is the Milwaukee brace. Okay, Milwaukee. You should know the names of this brace. Follow up. In the follow-up, we evaluate the patient on 3 monthly basis: 3, 6, 9, 12, 15, and 18. Okay, and what we evaluate the patient both clinically and radiologically. Clinically, weight gain, pain relief, range of motion, abscess, whether the swelling is decreasing or not, and the neurological recovery. We quantify assess the neurological status of the patient. And radiologically, if there is a decrease in the soft tissue shadow, disappearance of the erosion, return of the mineralization, graft, whatever surgically we have placed the graft, one graft, whether it has been taken up, incorporated or not, and fusion. Our aim is to fuse the vertebra. So the bony fusion is there or not. Sorry. So this is the last slide, and the take-home message is maintaining high suspicion if the patient is having back pain. Otherwise, normal active patient suddenly, if having say back pain and unable to walk with constitutional symptoms of weight loss, loss of appetite, especially comorbid patient, elderly patient, we should be highly suspicious in those cases. Further, tuberculosis of the spine. So early diagnosis is the essence of the tubercular containment, and that is required for the good results. Early diagnosis. Early MRI is the essential tool for diagnosis of the tuberculosis spine, as it takes around 3 to 5 months for the radiological X-ray appearance to come up to be get visualized, and not all patients can be treated by chemotherapy alone. When there is a gross mass effect that is compressing the spinal cord and there is a neurological symptom, only tubercular drugs, they does not heal up, they do not treat the patient, cure the disease. We may need surgery in those cases. So this ends my topic for today, tuberculosis of the spine. Thank you. If you have any queries, you can write to me. Just in your stage, you should be knowing you should not forget that this is almost always secondary. So you have to actively look for the primary cause, look for the primary tuberculosis, and the different stages by Kumar, pre-destructive, early destructive, and the mild, moderate, severe deformity, clinical radiological grading, and the diagnostic part, the lab parameter, the ESR, CRP, and the monthly test, and the Xray appearance. Typically, different types, the paradiscal types, anterior type, central body type, and appendicial types, different types of the lesion, and the erosion of the vertebral inflates and decrease in the disc space. These are the typical inflate erosion and decrease in the disc space are the typical features of the paradiscal type, and that is quite frequently the patient come to us with these pictures. So while looking at the X-rays of the vertebra, we should be quite vigilant in looking after these, the vertebral discs and the inflates. Okay, thank you so much. If you have any queries, yes, night cries, Dheeraj has mentioned, night cries are common because of the spasm. Patient is calm, and the pain is more in the nights. In the daytime, patient is active with the distracted with the other things, but in the night time, the spasm then is more. So the cries are more in the nights.